You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract. Welcome back to another episode of Beyond the Abstract. Today we're talking to Regina LaBelle about her recent article featured in the Journal of Addiction Medicine titled The First 100 Days, the Trump Administration and Changes to Addiction Policy. In today's episode, Regina discusses structural, budgetary, and personnel and data collection changes that have occurred in the last 100 days and the potential impact on addiction policy. Regina LaBelle is the director of the Center on Addiction Policy at the O'Neill Institute for National and Global Health Law at Georgetown University Law Center. She's also a member of the faculty at Georgetown University's Graduate School of Arts and Sciences, where she directs the Master of Science in Addiction Policy and Practice program, a program that she founded in 2021. Regina has a history of public service, including in the Biden and Obama administrations in the White House Office of National Drug Control Policy, where she was appointed acting director in the first year of the Biden administration. Under President Obama, Regina served as chief of staff at ONDCP, where she managed the agency's response to the overdose epidemic and the implementation of the National Drug Control Strategy. She also serves on the National Advisory Council on Drug Abuse at the National Institutes of Health. Now let's get into today's conversation with Regina LaBelle. Regina LaBelle, thank you so much for sitting down and talking with us today. It's great to have you on.
Thanks for having me.
I want to start with how you ended up where you are today. Tell me about what was it that led you to working in this field and being involved in the field of addiction policy?
Yeah, so there's the longer-term answer and the short-term answer. The short-term answer is that I started working in the Obama administration in the first year. I worked for Gil Kerlikowske, who I knew from my time as legal counsel to the mayor of Seattle. But I think the bigger picture issue and why I've stayed in this, working on this issue for so long, is like many people, I've been affected by substance use disorder. And I really, in thinking about this issue, I think that it was we talk about the opioid and overdose epidemic all the time, but it's really been a silent epidemic for, years and years and years. And I think about family members who passed, and I only later found out that they died from alcohol-related disease. I found out that they died from heart conditions related to their cocaine use. So I think really the idea of the number of people who are affected by this silent epidemic has really kept me in the field and has driven me to do something about improving the way we address addiction in this country.
Yeah. Now, before we get into the first 100 days of the Trump administration, I want to look back at kind of where we were and what has led us up to our current moment. So over the last decade or so, there's been a lot of great progress made in the arena of addiction policy. What was it that made this progress possible?
So I think that a lot of it was really, unfortunately, the opioid epidemic opened up a lot of people's eyes to the issue. And, there's a lot of racial issues involved as to why the certain population that was affected engendered more sympathy. And it was seen as an issue that affected rural communities as well as urban communities. And we were I was really pleased in the Obama administration and even in the Biden administration at the beginning too, that these were bipartisan issues and nonpartisan issues. We worked very closely with members of Congress and governors who we wouldn't necessarily agree on a lot of things, but we agreed that this needed to be a priority and that we needed to treat people with compassion. And so I think that, that's how we've made that progress, is because we've been able to kind of put aside a lot of partisan divisions.
Yeah. Well, I want to talk about your commentary in JAM, in the Journal of Addiction Medicine. It looks at 3 areas of addiction policy change that have occurred during these first 100 days of the Trump administration. Now, those include structural changes, budgetary and personnel changes, and data collection changes. We're kind of go through all of those, and I want you to talk to me a little bit about them. But let's start with structural. Tell me what significant changes have been made here in this particular area.
So I think one of the pieces I tried to stress in the commentary is distinguishing between what's happened already and what hasn't happened yet. Now, certainly structurally, the biggest change that's being proposed is the elimination of the Substance Abuse and Mental Health Services Administration in the Department of Health and Human Services. That would then be folded into the Administration for Healthy, AHA, the Administration for a Healthy America. It would be combined in that sub-agency in HHS. So basically, these specific agencies that were separately working on a variety of issues would all be combined under that one umbrella sub-agency in HHS called AHA.
Right. Okay. Now, let's talk about budgetary and personnel. So kind of walk me through this. Tell me about what are the changes that are happening and how might they kind of impact the addiction field?
Sure. I think so. The personnel piece, those have happened already. There's probably more to come, but we know right now that 20,000 people have had their jobs eliminated from the Department of Health and Human Services. And these are people, entire work groups were wiped out. And there are personnel reasons why they did it that way. So 10,000 people were, through the reduction in force. And then many other people lost their jobs through probationary employees or people who took the early out. So those 20,000 individuals, I'll give you one example of a work group that was wiped out. The National Survey on Drug Use and Health is the largest survey of its kind in the United States, and it gives us the annual survey of the state of substance use and mental health conditions in our country. It is done by an external entity. So there's an external entity that operates it's a door-to-door, a household survey, so people go door to door. But there's an entity within SAMHSA at HHS that basically, works with other agencies across the government to figure out what questions should be asked, how should the survey be changed, and then most significantly, they do updates so that we know the status of, how many people in this country in certain counties have substance use disorder or at risk for other conditions. Mental health conditions also are covered. Increasing rates of mental health conditions among young people. That all comes out through the National Survey on Drug Use and Health. That work group is left. Now, the new budget that has just come out, the new budget proposal has just come out, says that, we're going to continue to do that survey, but the people who run the survey at HHS no longer have their jobs. So there's a lot of uncertainty. I mean, addiction services are not well funded. They're not, it's not like this well-oiled machine. And anytime you take something out of the cog, you can really cause some serious breakdown. And then the third piece, which is the budget that you asked about, one thing's already happened. $1 billion has been clawed back from states. That money was sent to states during COVID. It wasn't for COVID. It was for a lot of other services. So that money's all been clawed back. Now, and I'll get to the proposed budget by the president in a minute, but that's really when you break it down structurally, personnel-wise, 20,000 people, and then $1 billion has been pulled back from states that had been used for basic services.
So there's one more here. It's data collection changes. Can you tell me a little bit about what is important to know here? What is this and how is this changing?
Sure. So that's one piece of that is the National Survey on Drug Use and Health, which I just mentioned. Again, we've lost a lot of our data collection capabilities over time. The Centers for Disease Control and Prevention collects all of the mortality data nationally from every state. The National Center for Vital Statistics kind of cleans the data up, provides it to the states get the data, send the data to CDC. The CDC then cleans up that data and provides it publicly. They release the mortality data once a month. CDC is really cut so significantly, both proposed and the budget cuts that have already occurred. So I'm left with a lot of question about what data capability will be available through CDC given all of these budget cuts.
Yeah. And you've touched on this a little bit already, but I want to go through anything that we might have missed. But you described in your commentary as a snapshot of a moving picture. And since your piece was published in mid-May, and it's early June now when we're talking, what significant policy changes have already occurred over these past few weeks that maybe our listeners should be aware of?
Sure. So several pieces that have happened. One is, the Congress is going through the reconciliation process right now. The most important thing for our listeners to know, I'm sure they're well aware of this, are the cuts that have been proposed, at least in the House bill that passed, now in the Senate, the cuts to Medicaid. The cuts to Medicaid could have huge impact on people with substance use disorder. One of the ways the majority of people who have substance use disorder are receiving their services, their treatment services through public pay. So either through the block grant or through Medicaid, most often through Medicaid services. There will be cuts to that. What Congress is saying is it's just waste, fraud, and abuse, but you can't cut $800 billion out of the Medicaid budget and think that that's all waste, fraud, and abuse. They are making work requirements. There's not a problem with work. The majority of people on Medicaid actually do work. The issue is, how will people be considered? What types of work is acceptable? If you are if you're recently released from prison or jails, and we know that a lot of people, 60% of people in jails and prisons have a substance use disorder and or a mental health condition. Question is, when how are they going to get a job? They often can't because of their felony record. So, and there's no provision to make it easier for them to get a job. So we're really you could potentially see the spiraling down of people. People in treatment, people who have other conditions, it's a tenuous healthcare system that we already have. And if the rug is pulled out from under them and they have to go through a waiting period or lots of paperwork to get the treatment that they need, we shouldn't be making treatment harder to get than an illegal drug. And unfortunately, that's kind of the system we're setting up. We're setting up that potential. So Medicaid was an important piece that we've already seen. It's before the Senate as of today. The second piece is the president's budget proposal. There were a couple things that I mentioned in the document that so there's a set of grants called PRNS. They're small grants that go out across the country. Regional and national significance. That's what PRNS stands for. Those grants in the skinny budget were all eliminated. And they're eliminated in this new budget proposal as well. The other piece of this new budget proposal that just came out Friday, May 30th, calls for combining the major mental health block grant, the substance use block grant, and the state opioid response grant. As we currently stand, if you combine those grants as they're currently funded, it's $4.6 billion. under this new proposal that the president sent to Congress, it's a $500 million cut to those 3 grant programs. Now, if you think about combining those, think about the Medicaid cuts. People who are receiving grants, receiving treatment in a state that doesn't have Medicaid expansion, and you cut Medicaid even more, and you're cutting those grants, again, there's no place for people to go to get the type of care they need. And so once again, we're making it harder for people to get, it's harder to get treatment in a world when, we still are at record rates of overdose deaths. It's come down, but still not sufficient. This is not over yet. And so it's a little nonsensical to be reducing it to that extent. So a $500 million cut. The other cut that has been proposed, again, Congress has to act on this, 37% cut to the research through a combination of things. And so the National Institute on Drugs of Abuse, National Institute on Alcohol, and the National Institute on Mental Health, the proposal is that they all 3 be combined. So that's part of the structural issue. However, as part of that combination, they're funding it at 37% less. So that means 37% research to go to either mental health, to substance use, either illegal drugs or alcohol. And then finally, I mentioned the Office of National Drug Control Policy at the beginning. That's where I used to work. The budget proposal from the president calls for removing the 2 main grant programs, which are the prevention program, the Drug-Free Community Coalition, moving that to HHS and cutting that significantly. It also calls for moving the Drug Trafficking Areas program to the Department of Justice. It doesn't call for reducing that budget, but the Office of National Drug Control Policy basically then will just consist of staff, and not having those prevention grants and the law enforcement grants really reduces the authority of the office as well as kind of the ear on the ground to know what's going on. Because that office is intended to set the strategy for drug strategy for the for all the federal government. And without those 2 grant programs, it would be much more difficult for them to be effective and to be in a position where they can influence things going forward.
A lot of amazing information. I do want to shift gears as we come to the end of our show and ask you for a little bit of wisdom. So I would love to know what kind of advice you would offer to others that might be interested in addiction policy, or maybe those who are just kind of getting into it and who are new to the field.
So, I think that it's the clinicians, their voice is so very important on this issue. People who work in the field, who are working with individuals with substance use disorder on a daily basis, or people who may use drugs and don't have a substance use disorder, hearing from them and being the eyes and ears for members of Congress or state officials, that's so important. You can't overestimate how much elected officials need to hear from people who can talk personally about how an issue has affected them or their patients. And I think that is one of the most important things, is just to remain involved. It is really difficult often, but there's so much has been done. We've done so much in a bipartisan manner over the years. And also, the other piece of advice is not to be partisan about this. That, we've worked with lots of Republicans and lots of Democrats on these issues. They needn't be seen through a partisan lens. We're talking about a chronic condition for many people that can be prevented, from which people can recover and people can be treated.
Yeah. Regina LaBelle, it's been great speaking with you today. Thank you again for stopping by.
Thank you.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.